This comes to one of the important parts of our symposium because it's the Servier Symposium, and you all know that without Servier's fantastic support, the Society just couldn't meet in the way it does. So, first of all, we would like to thank Servier for their support, and this is the symposium to engage in it. And I think we show them a warm round of applause for their support to the Society. Thank you. Having said that, this is not a commercial symposium at all, but it is related to subjects they're interested in. And by tradition, our first and introductory speaker is the President, and I don't think Babis needs much introduction, so please take over.
Thank you, Kennedy. In the next 2 or 3 minutes, I will set the scene for the speakers to follow, and I will let you know why we should protect people from both risk factors, because we know that CAD is a multifactorial disease, but fortunately it does not take an Einstein to treat the disease. However, it is very difficult to prevent the disease, because on general grounds, it's much more important to prevent than to cure. And if we, let's say on a population basis, prevent 10% of the people, then we have 3 times more reduction in deaths rather than treating 40% of the people who actually have the disease. So it's really, really important to prevent the disease. And this is the essence of the different approaches of the European Society of Cardiology. I've been part of several committees and consensus documents. These are the guidelines recently published, presented in the Rome meeting of the European Society of Cardiology and the European Society of Atherosclerosis, in which I had the honor to be a member of the task force. And one of the most core and integral parts of these guidelines is that if you have an addition of several risk factors, then you might have a risk that it's beyond imagination. And for instance, you can see in the graph that if you're a smoker, if you have a little bit of a high cholesterol, and if you are 60 years of age, then you have a 6% likelihood to die from cardiovascular disease in the future. And it's not like the Framingham we have to emphasize. It's 6% to die in the next decade, which is a really, really high number. So it's an accumulation of risk factors that really troubles us, because very, very frequently our patient does not have just one risk factor, but very frequently our patients have 2 or more risk factors. And for instance, our hypertensive patients, no matter where you come from, 50% of them have dyslipidemia. So we should not separate our efforts in treating one risk factor separately, but we should combine our forces and treat all risk factors, because cardiovascular disease is preventable through treatment of risk factors. But the question is, despite cardiovascular disease being preventable, we're not doing enough. And I'm going to show you my last introductory slide. This comes from the EuroAspire. This is a big cohort in several European countries, thousands of patients that they already had a cardiovascular incident, which means that they are categorized as very high risk, and we have certain goals for reaching for both blood pressure and lipid targets. And you can appreciate that only 60% of the patients, despite being at very high risk and already having had a coronary event, they treat their blood pressure appropriately. And the picture is even less satisfactory when you set a goal of 70 milligrams per deciliter, which is the goal for those patients who are at very high risk. So even if we are in Europe, we have the means, we have the knowledge, we don't treat our patients in the way that we should have. So this symposium will deal with these aspects and try to navigate us as to where there are any solutions where we can improve our patient treatment and reach the specific goals. Thank you very much.
Okay, well, thank you very much, Babis, for that. I mean, the data are out there for people to see. So, Stefan, also very well known to the Society as an ex-president, it's a great pleasure to welcome you to do your talk on impact of dyslipidemia and hypertension on the vascular wall.
Thank you, Kennedy. Please excuse my cold and my voice, but I will do my best. When I was asked to discuss about the impact of dyslipidemia and hypertension on the vascular wall, I considered that finally a simple way, not strictly exact, but simple, was to oppose arteriosclerosis and atherosclerosis. Beyond age, hypertension is the main determinant of arteriosclerosis, and beyond age, dyslipidemia is the main determinant of atherosclerosis. And we will see how they impact each other. Arteriosclerosis is mainly a disease of the media, and atherosclerosis a disease of the intima. Arteriosclerosis is mainly an issue of cell matrix and the combination and the relationship with vascular smooth muscle cells. And Nikos Stergiopoulos explained us how it works. And by contrast, in atherosclerosis, there is a lot of different cell population. So in the early time of atherogenesis, there is that is named the response to retention model. That is to say, in a very particular susceptible area of diffuse intimal thickening, you have an early lipoprotein retention, which is going more and more, which attracts the entry of monocytes and then leads to retention of lipoproteins and macrophage differentiation in foam cells, digesting this lipoprotein, attracting vascular smooth muscle cells from the media, and finally entering into the intima and leading to an advanced plaque. And it is named maladaptive inflammatory response because despite a lot of inflammatory cells, finally the plaque is not stabilized, but it is evolving. And it is very limited to the intima. And you see here with a 3D reconstruction in a not so old paper that lipids are rather deposited into the outer layer of the intima and macrophages in the inner intima layer, nothing to do with media. The atherosclerosis is associated with a number of cells, endothelial cells, vascular smooth muscle cells, we already saw that, fibroblasts, monocytes, platelets, immune cells, stem cells, a complete different system of arteriosclerosis. So how do we measure atherosclerosis in clinical practice with the carotid intima media thickness? And the high-resolution echo tracking system had made a lot of progress. And but we should keep in mind that a high carotid intima media thickness can be due to dyslipidemia, but it can also be due to hypertension and the control of wall stress by media thickening. Carotid plaque with echo Doppler or with MRI, and with MRI it is more and more possible to determine the vulnerable plaque, which associate a rich lipid core, a thin fibrous cap, and calcification. And we will see later how it works. And of course, the calcium coronary score that is more and more used in clinic. By contrast, arteriosclerosis, it could be used as arterial stiffness could be used as a proxy of arteriosclerosis. And we know how to measure it, by relating the functional and structural component, what we learned the last years is that this is mainly the change in the three-dimensional organization. And again, Nikos Stergiopoulos gave us several examples. So We have a rich elastin network. We have a number of musculoelastic complex, you see, 40 to 80 into the ascending aorta. And if you take into account the fatigue phenomenon of repeated pressure pulsatility breaking the elastic fibers, fatigue is a combination of amplitude of strain and number of cycles. Finally, this is local pulse pressure and age. And you break the elastin fibers, and then you increase the stiffness. And you see here in mouse disrupted elastic fibers. And it is exactly the same as we do in industry to be sure that shoes and other material will be long-lasting. All these last years with Patrick Lacollet, who is in the audience, we discussed among the most important determinant of this 3D organization of arterial stiffness. And beside elastin and collagen, certainly vascular smooth muscle cells, and his group has contributed to show that if you increase stiffness of the smooth muscle cell, you increase stiffness of the arterial wall, but also cytokines, cytoskeleton, proteoglycans, adhesion proteins, apoptosis, etc. So it is not only elastin and collagen, it is much more a complex phenomenon. Another difference is location. Arteriosclerosis, you can consider that finally this is mainly due to tensile stress, and this is at the entire side of the level of the arterial vasculature. Atherosclerosis is more located and it's dependent on shear stress at carotid bifurcation, at coronary artery, at ascending aorta. And here, beside that, there is an embryonic origin. And this is a work by Majewski and colleagues. And it is surprising to see that tissue from neural crest origin are finally, like the common carotid artery, not much susceptible to atherosclerosis compared to internal carotid artery derived from non-neural crest origin with other types of origin summits, splanchnic mesoderm. They are originating from proepicardium. They are absolutely not related to the ascending aorta. They are, by contrast, invading the ascending aorta. So it is not completely separated because there are contamination by other types of vascular smooth muscle cells, but clearly the embryonic origin of cells is playing a very important role. And I go very quickly through this experiment, but it is fascinating because you have an atherosclerotic prone region, which is the ascending aorta, and an atherosclerotic resistant region, which is the descending aorta, and there is a balance between pro-inflammatory cytokines and the OX system, one particular, very involved in the development of blood vessels, and you can express one cytokine to repress the other system, and inversely express the OX system and repress. And then you understand why atherosclerosis is developing on a certain cells from a certain embryonic origin in a certain part of the arterial wall. And last, the evidence from clinics and from epidemiology. What are the main determinants of pulse wave velocity? What are the main determinants of carotid intermediate thickness? If you look at the reference value for arterial stiffness collaboration, the two main determinants are age and blood pressure. If you look at the analysis done by Phil Shavyanchik and Marina Ceselia, you see that the number of studies, the largest number of studies, reported the influence of age and blood pressure, but very little lipids, and now more and more diabetes and metabolic syndrome. It's a little bit contrasting with a number of conditions which are known to be associated with an increased arterial stiffness, and mainly primary non-cardiovascular disease like end-stage renal disease or chronic low-grade inflammation like rheumatoid disease. What does it mean? It means that very likely there are other parameters which play a role and that we are unable to detect. Now, what are the determinants of carotid intermediate thickness? And from the reference value for arterial stiffness measurement and the work done by Julian Engelen in Maastricht and colleagues, you see here that when it is perfectly measured with high resolution system, the determinants are the classical one, those expected: systolic, blood pressure, smoking, diabetes, cholesterol, and BMI. So a contrast with arteriosclerosis and blood pressure and age. Now that I have opposed arteriosclerosis and atherosclerosis, I should say that they share common mechanisms. And this is clearly showed in various papers, but one good example, look at the data of the Rotterdam elderly study. The larger and the more severe plaque in the carotid artery or in the aorta, the higher the aortic stiffness. We do not know what is the cause and consequence, but clearly there is an association. So if they share common mechanism, apart from non-modifiable factors, there are modifiable factors like hypertension and dyslipidemia. But below, in the yellow square, those additional cardiovascular risk factors, they are crucially missing to all epidemiological data. Look at it. Physical activity, stress, diet, salt intake, social deprivation, etc., and mainly oxidative stress and chronic low-grade inflammation, which means that we have a very rough epidemiology for the moment concerning atherosclerosis and arteriosclerosis. You may ask a question: is stiffness necessary for the development of atherosclerosis? And indeed, if there is no plaque, pulse wave velocity is low. Is it because pulse wave velocity is low that we have no plaque? This is interesting, and only one animal experiments in mice and in ApoE null mice on the high-fat diet, who had an extremely high level of cholesterol, 10 times that we have in our blood. You see that elastic modulus is reduced in those with a selective lysyl oxidase inhibitors and who has reduced arterial stiffness. You soften the tissue and then you reduce, look at on the right, you reduce the number of plaque. So maybe we need stiffness to have plaque, and also conversely it may favor. And I will finish with hypertension as a risk factor for atherosclerotic plaque complication. Hypertension favors the damage induced by dyslipidemia. Usually what is done is a finite element analysis on cross-section with bioengineers, and you take into account the fibrous cap thickness and the pulse pressure. So you see here the larger the fibrous cap thickness and the lower the pulse pressure, the higher the number of cycles to go to rupture. And inversely, the thinner the cap thickness and the higher the pulse pressure, the lower the number of them. That is to say, the more fragile are the plaque for rupture. Interestingly, arterial stiffness is associated with intraplaque hemorrhage. And this is well shown in the Rotterdam study. And the intraplaque hemorrhage has been detected by MRI. And it is interesting because arterial stiffness here is measured with carotid femoral pulse wave velocity. So maybe this is through the global hemodynamics with an increase in systolic blood pressure, increased pulse pressure, maybe locally, but also at the general level. And it gives me the opportunity to show you some work that we have done some years ago relating the local stiffness and the possibility of plaque rupture. And with the new echo tracking, you see here 128 radiofrequency line, it is possible to calculate this tension at each of those lines, all along a 4 centimeter. And Anna Paini from the Brescia group worked on that and looked at what can be named a bending stress. That is to say, the plaque can be characterized as being stiffer than the adjacent common carotid artery. So you can determine a kind of bending stress, cyclically damaging the plaque with all repeated pulsatility. And you see in yellow here, in a common carotid with plaque, you see here at the site of the plaque that there is a strong reduction in distension. So when you look at the various population, what you see is that when you have a diabetes and dyslipidemia, you have much more often stiff plaque than soft plaque. So more at risk of fatigue of the adjacent arterial wall and then rupture. And combining with MRI, this pattern has been shown to be much more often associated with vulnerable plaque, because in those patients, 27 patients, we've done a complete MRI analysis. So we determined the lipid core, the fibrous cap, the calcification. We classified the plaque as vulnerable 1, 2, 3, 4 according to AHA criteria. And finally, we observed that vulnerable plaques are more often associated with high bending stress or strain, more simply. So in conclusion of these various elements, we can say that hypertension and dyslipidemia differentially impact the large artery wall, that hypertension is a greater determinant of arterial stiffening than dyslipidemia, that dyslipidemia plays a more important role than blood pressure in the development of atherosclerotic plaque. Both interact to favor arterial wall thickening, plaque development, and rupture. Dyslipidemia hypertension may be due to the common additional cardiovascular factors. Usually we do not know them, but chronic low-grade inflammation is playing a more and more important role. Mechanical factors play a role, LDL entry, LDL retention, plaque rupture and fatigue effect, but do not neglect the local stiffness effect. And finally, pharmacological reduction in arterial stiffness may complement the effect of cholesterol-lowering drugs in treating cardiovascular disease by regulating at least two possibilities. First, endothelial permeability, but also the maladaptive inflammatory component of atherosclerosis. And this is what we will see in the second and third talk, more on the clinical aspect. So thank you very much for your attention.
We have a little time for one or two points if people would like to ask anything before Professor Strika-Boudier's clinical talk. I'm going to ask a little bit. The neural crest, the embryonic origin story, Stefan, we don't have easy markers for those clinically or in humans, really, do we? But I'm not sure I really get the evidence that the separation between the two origins in terms of atherosclerosis is very impressive, is it? I mean, if you had an argument about central pressure, you could argue pretty strongly that atheroma occurs in the neural crest origin. Maybe less, but just as often.
No, yes, I take your point, but I think this is a very important way of considering that atherosclerosis does not develop everywhere. It is not only a question of shear stress. It is a question of the substratum, which are the vascular smooth muscle cells which are in this particular artery location. What are those vascular smooth muscle cells in the ascending aorta or in the coronary artery? They are not the same. Why do we not have any atherosclerosis on the upper limb? And for years, it has been considered that it was mainly a shear stress or hemodynamic conditions, but it is not enough. And this is why I advanced that hypothesis. But I agree with you that if it were entirely that explanation, we should find on one side all atherosclerotic segment, and on the other side the whole arterial system, which is not the case.
I think looks like we can move on, I think.
Okay. Now, Harris Trigger-Boutier does not any introduction, but I think he will deal with very interesting and very intriguing question. Should we or should we not treat all of our hypertensive patients with a statin? Harry.
Thank you, Chairman. Ladies and gentlemen, the question, should statins be given to all patients that are hypertensive, is based on a large body of work that has been done in the past 25 years. I think statins are now probably the most investigated and probably also almost the most used drugs in general practice. And it all started in the early 1990s with a number of trials, and I've given one historical example here based on the 4S study with simvastatin, where coronary heart disease patients with an elevated serum cholesterol were treated with simvastatin, and it was clearly proven in that study that there is a reduction of mortality in this case by the treatment with the statin. At the same time, some other studies were performed with then available statins. The West of Scotland study is a famous one. And in the meantime, we have now data on 20 years of use of statins. And here is from a recent publication from the West of Scotland study in Circulation, published a few months ago, the 20-year follow-up data on pravastatin, and again, with different measures of outcome here, hospital admissions, cardiovascular disease, myocardial infarction. It is shown that pravastatin is, over a long period of time, effective in reducing this morbidity and mortality. So there is a legacy effect. You would expect these curves ultimately to join each other again, but this does not happen, at least over a 20-year period. So definitely there is a strong argument for long-term effectiveness of statins in reducing cardiovascular morbidity and mortality. Now, originally, these studies were all focused on patients that had coronary artery disease and had elevated cholesterol levels. But that has changed in the past 10 years. In the past 10 years, more and more primary intervention studies have been done with statins, and it is now been part of the consensus papers in various parts of the world, in the United States, the American Heart Association, in Europe, the European, and then of course the British, who are within or out of Europe, I don't know. The nice data also say that rather than a primary, rather than a secondary prevention on top of a already existing cardiovascular disease, perhaps statins should be used in patients which have a global risk assessment, which is in the order of 10% when it comes to coronary vascular disease, and if specifically focused on mortality, perhaps a 3 to 5% risk there. So an intermediate risk, or still a relatively high risk, is indeed now regarded in these guidelines as a reason to start treatment with a statin. Now, the picture on the hypertension question and primary intervention has been rather changed, or is discussed quite a bit now on the basis of the HOPE-3 trial, which was published again a few months ago in the New England Journal of Medicine in 3 separate papers by Salim Yusuf and his associates. And in the HOPE trial, the design was such that it was a double-blind, randomized, placebo-controlled trial, and no longer was here the inclusion, the level of cholesterol or the existence of coronary artery disease, but it was simply a 2x2 factorial design in over 12,000 persons, men above 55 years, women above 60 years, which have one additional risk factor besides their age. And that risk factor could be hypertension, could be diabetes, one additional risk factor. And the treatment was then either a statin, in this case rosuvastatin, or in blood pressure lowering treatment, the combination of condazartan and hydrochlorothiazide. And the follow-up was on the average 5.6 years, but in a number of cases went up to about 7 years in a follow-up. And quite a surprising result came out of that trial, in that the rosuvastatin trial was in that particular intermediate risk group who could have had hypertension or diabetes and the age as given here, that rosuvastatin was clearly effective in reducing a number of outcome variables, such as stroke, such as myocardial infarction and coronary revascularization. And this has been published in the New England Journal again a few months ago. In contrast to the antihypertensive treatment, condazartan hydrochlorothiazide, no significant effect on the outcome here in the cumulative index, a slightly but certainly not significant effect on stroke, and the cardiac parameters, no significant difference. So, and this was not by definition a hypertensive population. It was a single risk factor population, and it showed that clearly the statin was effective in reducing the risk as opposed to this particular form of antihypertensive treatment. And the conclusion that Yusuf derived from this is that indeed, in a more general sense, when there is a risk factor present, a statin might be useful to use. Now, this has been reinforced by another recent publication that was published online a few weeks ago in the Lancet by Collins and co-workers from the United Kingdom, and they have gone a long way in analyzing a large number of studies, hundreds of thousands of patients that have been involved in that particular analysis, both primary and secondary prevention, and they've concluded massively, and the slide is too detailed to show you every part of it, but in a number of situations, age-related, history of vascular disease-related, and also diabetes and hypertension. And in hypertension, even treated or non-treated, no difference. The outcome of a statin treatment, or better, as they say, LDL lowering. I will come back to that issue in a minute, but the treatment was done with a statin, at least here. The statin treatment showed a significant better outcome in terms of risk reduction than when LDL was not lowered or when the statin was not used. So indeed, over a range of risk factors, including hypertension, the statin has a risk-reducing effect. The issue on LDL lowering is an important one because that is a matter of debate. And in the consensus paper by Collins published online in the Lancet a few weeks ago, the relationship between the LDL level and the proportional reduction in major cardiovascular event rates is shown here to be not entirely linear on a non-logarithmic scale. If you make a logarithmic scale out of this, it would probably be linear, but I'm not sure whether that's fair to treat it that way. And this non-linearity at least suggests that the cholesterol reduction is strongly associated with the risk reduction, but such an association is not necessarily, of course, a causal relationship, because other ways of reducing LDL are sometimes not as effective in reducing risk as the statin-induced is. And this has been a subject for pharmacological investigations quite intensively in the past years, and the pharmacological studies at least show that there are a number of additional effects that may contribute to the overall action of statins in cardiovascular risk reduction. To name a few here, the improved endothelial function, the reduced vascular inflammation, already indicated by Stéphane Laurent as an important factor in the combined hypertension, atherosclerosis area, and in stiffening probably also platelet aggregability, stabilization of the atherosclerotic plaque, immune suppression related, of course, to the inflammatory effect. So there is room for considering that statins, in addition to the LDL lowering, have additional effects that do contribute to the risk reduction. And I think these pharmacological evidences need to be further studied in the clinical situation, because it could explain why the additional effects of statins do occur in even non-LDL elevated patients, as was done in the HOPE-3 trial. And the use of statins simply linked to atherosclerosis and elevated LDL levels needs rethinking. And I think, again, the HOPE-3 trial certainly stimulates that work that should go back to the laboratory and to clinical studies where this is further looked upon. Now, finally, again, from the recent Collins paper in The Lancet, coronary, cardiac stroke, other vascular reduction of the total number of deaths here, and the rate of control in terms of LDL lowering much better. Other diseases which have been associated sometimes that statins would either be effective or have the reverse effect and would lead to another increase in risk are disputed there, or are rather shown that are not the case. That's the lower part: cancer, respiratory, trauma, other non-vascular disease. No difference between the statin use and the non-statin use in that respect. So that has brought the Collins and Associates to a number of conclusions, which I would like to use also as a summary, because I think they are very well formulated in their paper. That is that effective low-cost statin regimens, for instance, a daily or a cost of about £2 per month, can reduce cholesterol by about 50%. That large-scale evidence from randomized trials shows that each millimolar reduction in LDL cholesterol produces a proportional reduction of about 25% in the rate of major vascular effect, coronary, myocardial strokes during each year, and that the risk is thereby reduced by about 45%. That a statin regimen in about 5 years in 10,000 patients would prevent major vascular events in about 1,000 patients at high risk and 500 at lower risk, so in primary prevention. And that creates room for the use in also hypertensive patients. On the counter side, of course, are the side effects, and this should not be neglected. I think the decision to use a statin in hypertension therapy is always an individual decision. Epidemiologists, fortunately, do not determine what a clinician must do on a one-to-one situation with a patient. And on the counter side is the side effects. And I think a decision there is important. The side effects that have been reliably related to statin therapy are myopathy, muscle pain or weakness combined with increase in creatinine kinase. That's the proper definition of myopathy. New-onset diabetes, and an increase in stroke is certainly, hemorrhagic stroke has been associated with statin therapy. Typically, the treatment of 10,000 patients for 5 years with a statin will cause about 5 cases of serious myopathy. There might be more cases of muscle pain, but that is very hard to relate when compared in placebo-controlled trials, whether this is a drug effect or whether it's a placebo-related effects. 50 to 100 new cases of diabetes and 5 to 10 hemorrhages, strokes. If you offset this overall against the profits of statin use, then of course the balance is far on the positive side. But again, and that would be my last words, Chairman, the individual decision on a statin use in a hypertensive patient is the balance between the profitable effect that can be reached and the side effect that one might be confronted with, and it is an individual decision that should be made in that respect. Thank you very much.
Thank you very much, Harry. We can take a couple of questions. My co-chairman has one. I just want to make a comment. I think a very important point that you raised is the one that is derived from the 20-year follow-up after the pravastatin study, which showed clearly the memory or legacy effect, which means that we have to act as soon as possible in order to provide a better outcome for our patients. So, did you have, okay. Would you like
Just a quick question about all statins. Are they the same in terms of the benefit versus the risks that you talk of here?
In general, there might be a dose difference, of course. Not every statin is dosed on the same milligram basis. So there is a dose range for the individual statins. In the Collins analysis, the large one, the overall, the Lancet paper that was just out, it is taken as a group effect, that there are no differences in terms of the individual statins in the effect to be expected.
Any other questions? Jan, please.
Thank you very much, Harry. I vividly remember the discussion about the pleiotropic effects of antihypertensive drugs, and it came out that it's the blood pressure lowering that counts, nothing else. Although maybe not all people agree, but this is certainly my conviction. Now, you're talking about pleiotropic effects of statins. Is it possible that these pleiotropic effects are distal from the LDL lowering? In other words, that they are mediated by LDL lowering?
That's a good point. And it's always, when you correlate two things like that, that the causal factor is not defined. It's a correlation. It's a relationship between two factors. I think the pleiotropic effects are thus far mainly based on animal experimental or in vitro type of studies, and this needs really good clinical work to follow up on that. On the other hand, still trial data do suggest there was a recent one, I forgot the name of the trial, but with ezetimibe to lower in addition LDL. And it was a very strong lowering that could be obtained, but little extra effect on the risk there. So I think the idea of just LDL lowering might not be enough. For a statin, it's a group effect, certainly. But if you use other classes of LDL lowering agents, you may not obtain the same effect. And that, to me, does suggest that pleiotropic actions may play a role in addition to the obvious primary LDL lowering effect.
Okay, thank you very much.
Okay.
Right. Well, the last paper is going to be by the President again, practical solutions for hypertensive patients.
Thank you very much, Kennedy. I will move into a more practical, this is my disclosure area. Now, this is the structure of my talk. Why should we care? What could we combine? Because this might be the solution, and should we combine all ingredients in one? So first, why should we care? This is very important. You can see, and we can obviously anticipate that the higher the blood pressure is, the higher the risk. But what is very important is that if you add another risk factor, then actually for the same level of blood pressure, you double your risk. So it's a multiplication effect, and we have to be very aware of the coexistence of risk factors. And another thing that is very important is that we overload our patients with drugs. So 1 out of 3 patients are taking 3 antihypertensive drugs or more. So we overload our patients with drugs, and this is something that we have to bear in our minds when we treat our patients. Now, what to combine? This is a very important, very pertinent question. First of all, in terms of combination, before we combine, we usually increase the dose of the drug. But you see what happens is that if you increase the dose, then you gain an increase in efficacy of 22%. But when you add a drug from another class, then you have almost 100% increase in efficacy, which means that you have 5 times more effectiveness if you combine 2 different classes of agents, because you act on different pathways. This is something that we have to bear in mind when we choose the next step in our medication. Now, if we want to combine an ACE inhibitor and calcium channel blocker in a study, which is a good proposal for treating both conditions, we will discuss if there's a synergy at the clinical level, and we take it in a step-by-step procedure. And first of all, let's see why we should combine, or we could combine, an ACE inhibitor and a calcium channel blocker. But first of all, why choose an ACE inhibitor over an ARB? This question has been answered by a big meta-analysis that was published in 2012. It involved 76,000 patients on one hand and approximately 1,000 patients on the other hand. And it was shown that regarding total mortality, there was a decrease by 10% in the group that took ACE inhibitors, whereas there was no decrease of total mortality whatsoever in the ARB group, which meant that you may have two different classes of agents that they decrease probably to the same extent your blood pressure, but the benefit in terms of all-cause mortality is only in the ACE inhibitor class of agents. There was no decrease there, and only ACE inhibitor reduced mortality. And if we dig further into this meta-analysis, we can see that the greater effect is mainly driven by studies such as the ASCOT, the ADVANCE, and the HIVET, in which a particular ACE inhibitor, which is perindopril, was used. So this is the rationale for choosing an ACE inhibitor. And this meta-analysis was replicated in diabetic patients, and again, a few thousand patients in both arms, and it was shown that it was only ACE inhibitor that they reduced the major endpoint, whereas there was no evidence for the ARBs. So there's a superiority, at least on clinical grounds, of ACE inhibitors. And what we know now, moving to the synergy with another class of agents, which is calcium channel blockers, there's a rationale to use combined these two classes of agents because they preferentially protect from certain endpoints. And from this meta-regression analysis, for the same reduction in blood pressure, we have the ACE inhibitors protecting from CAD, and we have the calcium channel blockers preferentially protecting from stroke. So you have different benefits from different class of agents, so you can combine the benefits if you combine the agents. Now, we have other evidence of combination and synergy. We know the accomplished study that was published a few years back, we had the same reduction in blood pressure, systolic and diastolic, but clearly there was a clear benefit in the arm of benazepril plus amlodipine. So the clinical benefit is there despite the same reduction in blood pressure. And we also had this celebrated ASCOT study. Some of the participants are here in this room, in which it was shown that despite, again, the same reduction in blood pressure, systolic and diastolic, there was a divergence of the event line showing that the combination of amlodipine plus perindopril was much better in terms of clinical events compared to the atenolol-based regimen. And something that some people in this room are clinicians, and they know very well that something that troubles us when we administer calcium channel blockers is the edema. And this can be counteracted with the addition of either an ACE inhibitor or an ARB. And in this meta-analysis, it involved 25 trials. The effect of reducing the edema, which is something that it is a benign complication, but it's a complication that prevents our patients from taking the drug. The reduction was much more higher in the combination with an ACE inhibitor compared with the ARB. Now, regarding the evidence that we have on an ACE inhibitor and a statin, this is a study coming from my home country, Greece. It was shown that if you add an ACE inhibitor on a statin, then these are CAD patients, then you have a greater reduction, relative risk reduction of 34%. And if you add a statin on an ACE inhibitor, then you have an additional 63% reduction, relative risk reduction in terms of cardiovascular death and non-fatal MI. So clearly there's a synergy of these two types of drugs. And if you combine now the three classes of agents, combining an ACE inhibitor and a calcium channel blocker and a statin, now introducing a drug counteracting dyslipidemia, we have more evidence regarding this triple combination. This is a post hoc analysis we did from the Europa study, a big and celebrated study in CAD patients, and it was shown that when perindopril was added to the calcium channel blocker and the lipid lower agent, we had a further reduction in the composite endpoints or in the individual endpoints. And depending on the endpoint, the reductions were 46, 58, and 71. So clearly, when you add another drug on a certain combination, you gain more benefit. And in another analysis of the ASCOT study, it was shown that if you have, on one hand, the combination of atorvastatin, perindopril, and amlodipine, and on the other hand, you have the comparator, which was atenolol with a thiazide diuretic and a statin, clearly, in all the endpoints there was that they were analyzed, there was a clear benefit in terms of preferential effect of the combination of atorvastatin, perindopril, and amlodipine that ranged from 24% to a little bit more than 40%. So the combinations actually act at the clinical level. So the question is, why do they act at the clinical level? Are there any explanations on a vascular level? And maybe they are. Of course they are, because we know all these three drugs, and I won't go into detail, they protect from the initiation of atherosclerosis and from the destabilization of the plaque. So they act in all forms from the beginning of the formation of the atherosclerotic plaque to the occurrence of the acute coronary events through different mechanisms. I'm going to highlight a couple of those. Now, this is the endothelium we know very well. It has a normal cycle life that goes from life to death, which is a programmed death, and it's called apoptosis. And it's happening because the new endothelial cells have to take place and to replace the aging endothelial cells, so we have a regeneration. But this has to happen at a temporal sequence that is predefined, because if we have increased apoptosis, then this is the figure I picked in order to represent what happens to the endothelium. It's like we're having cracks in the pavement. So we have an exposure of the medial layer to the lumen, and this creates an initiation of the cascade of the atherothrombotic events. So definitely increased apoptosis is not a good thing, and we know that several classes of agents have a beneficial effect, and although we could say that it is a class effect regarding ACE inhibitors, definitely some ACE inhibitors such as perindopril have been shown to reduce apoptosis to a greater extent compared to the other ACE inhibitors. Another piece of evidence that regards some of our work that we did a few years back, almost a decade now, it's the response to inflammation. We know that inflammation may be a triggering event in the cascade of atherosclerosis. So what we did in this experiment is we vaccinated people and we induced a temporal inflammatory response that lasted for 8 hours. And we pre-treated some of them with atorvastatin. So what happened was that when the patient, the volunteers were not pre-treated with atorvastatin, there was a reduction in endothelial function, which meant that the inflammation actually created endothelial dysfunction. But when those volunteers were pre-treated with atorvastatin, there was an abrogation of the effect, so there was no inflammatory dysfunctions whatsoever. Moving to another explanation, we know we have been discussing vividly these 2 days. Peripheral and central pressure are not the same. The increase towards the periphery to a varying effect. We have shown, Carmel has been debating that, but definitely there's something there that might substantiate a better predictive value of central blood pressures compared to the peripheral blood pressures. And we'll go back again to the Ascot study, in which I will remind you that despite the same reduction in peripheral blood pressure and systolic blood pressure and diastolic blood pressure, there was a clear greater benefit in terms of the drug regimen that included perindopril and amlodipine. So the question was why, despite the same reduction in peripheral blood pressure, we had a greater reduction in events, because we were discussing earlier that the greatest advantage when you treat blood pressure is through the blood pressure reduction and not due to other pleiotropic events. The answer, at least partly, came from the CAFE study, which investigated the effect on central blood pressures. And what this graph shows here is, despite the same reduction in brachial blood pressure, there was a greater reduction in central systolic pressure in the arm of the study that included the perindopril and amlodipine drugs. So probably a greater reduction in central blood pressure by specific drugs might be one of the reasons why these specific drugs might have a better clinical outcome compared to other classes of agents. And now, should we combine these three different classes of agents in one? Actually, we have a big problem in our clinical practice that we sometimes neglect. Actually, most of the times we neglect this problem because nowadays we have so efficacious regimens both for treating hypertension and for treating dyslipidemia, but no drug is effective if it's not taken. So we know that adherence to treatment, especially if you take too many drugs, decreases rapidly over time. So it's only 35% at 6 months. And we have data from the OnTarget study, and these are very impressive data. People who were not adherent to the medication had 4 times more likelihood to have an adverse cardiovascular event. Not only 1 or 2, 4 times higher likelihood, just because they were non-adherent. So this is really, really important in terms of treating our patients. And this creates a vicious cycle, you see, because if people are non-adherent, events come into place, and it's a natural tendency of our patients to blame not the non-adherence, but the drugs themselves. So they keep on increasing the non-adherence, so this creates a vicious cycle that increases further the events. So this is particularly important when we discuss with our patients, when we try to persuade them to take the medication. So this is what happens. We ask them to take more than 100 pills, and then we ask them to walk in between. So this is a real life situation, and we act like as we are authorities, and we should be authorities, but we don't take into account this the expression of this poor man when he's confronted with so many drugs. But there are simple solutions. There might be more there are different levels to combat, such as state educational levels, but there are simple solutions. And if you combine all drugs in one fixed combination, then by this simple, let's say, move, you increase this is a meta-analysis, you improve your adherence by approximately 25% by just making a simple move. And this increase in adherence, when you combine all drugs in one, has an impressive improvement in outcomes, both cardiovascular, coronary, and cerebrovascular. So combining not only increases adherence, but also it has a very positive effect in the outcome, which is, of course, what we care of. And specifically for the types of drugs that we're discussing today, antihypertensive agents and statin, you can see in this 12-month follow-up study, there was an impressive doubling of the adherence if the drugs were combined into a single combination. And this is a massive meta-analysis that was ordered by the European Society of Cardiology, and it was published a couple of years ago, showing that if you achieve good adherence with statins and antihypertensive drugs, you see that you have a great reduction both with statins and both with the antihypertensive drugs, both in terms of cardiovascular disease and total mortality. And the results regarding total mortality is much, much more impressive. And mind you, this is a meta-analysis dealing with almost 2 million people. This is a huge database. Okay, are we convincing our patients? In the guidelines that I had the honor to be part of, we finally made a statement to simplify the drug regimen when this is available. So we have clear now recommendation to simplify, because there has been a debate, especially in the hypertension field, there has been a debate as to when to combine the drugs. Should you reach a level of non-responsiveness in order to combine the drugs? Now we're moving to concepts of earlier stages to have a fixed combination. So I would say that we shouldn't settle. We have the best drugs available, but we don't have the results that we would have hoped so far. So we shouldn't settle. And sometimes the solutions are much more simple than we think. So these are my conclusions. Cardiovascular risk factors do often coexist. Cardiovascular disease is indeed preventable through treatment of risk factors, and treatment goals are not achieved, and this can be due to multiple risk factors, but clearly a great deal of that is due to poor patient adherence. So it's better to combine in a fixed drug combination, because this increases adherence. We achieve our goals earlier, and we saw earlier why this is important in Professor Boutier's talk, and we decrease eventually the events. And well, to combine, there's a superiority in terms of effectiveness regarding clinical events of ACE inhibitors. Perindopril has the greatest wealth of evidence in all the cardiovascular continuum. Atorvastatin acts in synergy with amlodipine, and also finally, if we combine two antihypertensive agents with a statin, we get the most benefit we can from our hypertensive patients that have in combination dyslipidemia. Thank you very much for your attention.
We're a fraction behind schedule. Any quick questions people would like to ask? Okay, so statins, Lorenzo.
I have a practical question. When you combine more than one antihypertensive drugs in fixed combination with statins, you should give it on the bedtime. Is it?
Okay, that's a very good question. Yeah, that's a very good and practical question. Actually, there's a misconception as to what is the right time to give the statin. Preferably, most of the statins should be given at night, because the synthesis is in the morning, so we have to have the peak levels of the drug late night, early morning, so as to inhibit the synthesis of cholesterol. But for long-acting statins, such as atorvastatin or rosuvastatin, this does not make any difference. So for this particular combination, there's no problem in giving the combination, the fixed combination, at what time you would think it's appropriate for your patient.
Okay. Well, Mr. President, thank you very much for finishing up the symposium. Thank you very much. I think we failed to give Stefan a hand after his very nice talk. So my job to thank all the speakers, to thank Servier again for its sponsorship, and thank you very much. Its posters, please don't forget while you're guzzling.